Hi everyone, we're back for part 4 of the chapter 11, abdominal pain, and we're going to be talking about cirrhosis and liver failure. So when we talk about cirrhosis, we're talking about a complete hepatocellular injury to the entire organ. It results in fibrosis and nodular regeneration, and then there's distorted liver architecture. Some of these changes include the liver parenchyma, which can cause a disruption in the vascular, the biliary, and the lymphatic vessels. Cirrhosis is also considered permanent and irreversible, but cirrhosis and fibrosis are not synonymous. So fibrotic changes are characteristic findings of cirrhosis. So in the U.S., cirrhosis is the leading cause of death in individuals over the age of 40 and is usually caused by chronic alcohol abuse. We also know with cirrhosis related to alcoholism, there are several nutritional and vitamin deficiencies that can occur. Other causes of cirrhosis and liver failure are listed on this slide. It's reported that greater than 30,000 people in the United States can die from liver disease that's caused from alcohol abuse. And then 3 consequences of alcohol abuse include a fatty liver, can induce alcoholic hepatitis, and alcoholic cirrhosis. Let's talk a little bit about primary biliary cirrhosis. It almost exclusively affects women between the ages of 40 and 60. It's an autoimmune disease that causes destruction of the intrahepatic ducts, resulting in cholestasis. And other autoimmune diseases have been linked to the development of primary biliary cirrhosis, such as scleroderma, Raynaud's syndrome, autoimmune thyroid diseases, celiac disease, and Sjögren's syndrome. Sorry for that pause, but when I went to look to see if there was a reason why smoking is associated with the decreased risk of this condition, there's mixed reviews on it. There's several different studies that are out there, but there really is not a definitive answer for it. Other causes of primary sclerosing cholangitis could be Budd-Chiari syndrome. This is a disorder that results in a clot in the hepatic vein, and so therefore there's outflow obstruction. The data shows that definitive diagnosis of this condition is only approximately 65 to 75% of the cases, and that in the Western Hemisphere, most clots that are seen in the hepatic veins are associated with a coagulation issue or myeloproliferative disorders. And it's important not to forget that malignant tumors that originate with the liver or a metastatic renal carcinoma could be causing an obstruction in this area. Some other causes include hemochromatosis and Wilson's disease, and both of these are autosomal recessive metabolic disorders that present with dysfunction in the liver and can lead to cirrhosis if left untreated. We know that the liver is the primary organ involved in the metabolism of iron and copper, so both of these are overloads. So hemochromatosis is the overload of iron, and Wilson's disease is the overload of copper. Let's talk next a little bit about the pathophysiology of cirrhosis. With cirrhosis, the lobular effect of the liver is now replaced with a a very disorganized pattern. There's bands of fibrous tissues that surround the hepatocytes. We know that the liver tries to regenerate itself, and during that repair process, the microvasculature of the tissue changes, and there's increased resistance to blood flow, which can cause portal venous hypertension. It can also develop a set of collateral vessels, and these vessels aren't as efficient for normal circulation as the original vessels were, and can lead to portal hypertension. There can be histological changes in the cellular components of the liver, and these changes can tell more about what type of injury has occurred. Okay, let's talk about drug-induced liver failure, and it can be the result of the drug's metabolism, or several drugs together. The toxicity may occur because the metabolism of the drug has been enhanced, altered, or if there's some unknown process that's going on. And patients who have a hypersensitivity reaction to a drug may develop hepatotoxicity secondary to the formation of the drug metabolites that are created. I'm going to let you read this slide on the pathophysiology of these two conditions. And let's talk a little bit about how cirrhosis and liver failure may present themselves. So you may have your patient who has increased weakness. They may have a loss of appetite and weight loss. They are known to have fatigue, and often, depending on what the cause of the cirrhosis is, there's malnutrition seen. You may note that there's an upper GI bleed. They can also have enlarged abdomens from ascites. There can be encephalopathy and confusion that can lead to comas. On exam, you may notice that the patient is experiencing abdominal pain. You may palpate a firm liver edge or an enlarged liver. There may be generalized muscle wasting away and palmar erythema, so redness to the palms. You also may notice that there is varicose veins because of obstructions in the microvasculature, and therefore blood flow not returning to the core as it should. The skin may be jaundiced in color, have that golden hue, and you may notice that first in the eyes, but the patient may also complain of itching, and as the bile salts are collecting under the skin, that can cause that itching. You can see bruising, swelling to the lower extremities. If there is ascites, then when you're going to assess that, when you're palpating, you may notice a positive fluid wave. There can be enlargement in the spleen. You can see hemorrhoids as the same rationale for the varicose veins, and you may notice that there is blood in the stool. Some diagnostic tests that you're going to be checking are, of course, are your liver function test. You're going to be looking at the ALT and the AST elevations. If there's concerns for alcohol ingestion, you may want to check a GGT. Your alkaline phosphatase may be elevated if there's biliary obstruction. Due to nutritional poor nutrition status, you will notice that the albumin levels are low. You may want to do a liver biopsy to learn more about what's going on, and they will note a longer PT time, and there may only be a mild elevation of the bilirubin. Your differential diagnosis may be a little different because it can be so different with each different cause, so the challenge is determining the cause to prevent further liver damage. Management is going to be dependent on identifying and removing the causative agents and treating the symptoms. So let's talk a little bit about the specific types of liver diseases. The first one, alcohol-induced liver disease. So of course it makes sense that you're going to educate your patient to abstain from alcohol. You're going to offer dietary supplementation. You want to increase their protein intake if there's no signs of encephalopathy. But if there are signs of encephalopathy, you want to decrease the protein that's taken. You want them to be on supplemental vitamins and minerals. There's a possibility that they may need a liver transplant, and it's important to be sure and manage for any complications. These complications can be related to portal hypertension, ascites, and as we mentioned briefly, hepatic encephalopathy. These patients may have anemia, they may bleed, They may even be found to have a hepatocellular carcinoma. On table 1114, there's a good example of the treatment for the specific complications associated with alcohol-induced liver disease. So got ahead of myself. This is the some of the complications that may be seen with liver disease associated with alcoholism. The most important thing with this disease is, though, to manage the portal hypertension. We talked earlier about the collateral circulation that develops between the portal and the systemic circulation, and this is not as strong a circulation loop as the original is, so it's important to be able to assess for any weakened walls in the vessels or any tortuous vessels called varices, because if these varices are within the esophagus or in the top part of the stomach, the patient can have issues with bleeding when the portal pressure gets too high. Let's talk briefly about primary biliary cirrhosis. Treatment is based on the symptoms that you have. Itching is one of the common side effects of it, and Questran, chlorestramine, helps relieve that itching with cholestasis. It helps to lower the serum bile acids and increase intestinal secretion of bile by preventing its reabsorption. Rifampin has been used to help treat the itching, as Zofran is to help with the itching. Because you're altering the absorption of the gut, fat-soluble vitamins are known to be deficient, and A, D, E, and K need to be replaced orally. Treatment may also include some immunosuppressive agents that help reduce the alk phos and the bilirubin levels. Ursodiol has also been found to be helpful, as it stimulates excretion of the bile by the liver. Your patient may need to have surgical reconstruction of the biliary tract, and those are all things that will be done by the hepatospecialist. We talked briefly about hemochromatosis, which is the increase in iron, and treatment for that would be weekly phlebotomies of approximately a unit of blood, which is 500 milliliters, which would bring down the iron stores by about 250 milligrams of iron, and you do that until iron stores are depleted. You would educate your patient on a low iron diet, and then also there is a medication called deferoxamine, which is an IV medication that helps pull iron out of the blood. So we talked about Wilson's disease is more with younger children, and it's too much copper, so you'd advise your patient to be on a low copper diet, no legumes, animal organs, or shellfish. Oral penicillamine increases urinary excretion of the copper, and then oral zinc binds with the copper to help excretion in the feces. Follow-up and referral for these individuals, as we talked about, with advanced liver disease should be seen by a hepatologist. A liver biopsy is what will be needed to make a definitive disease. Patients with end-stage liver disease will eventually end up at a liver transplant facility. And those individuals that have chronic or advanced liver disease will require ongoing monitoring of liver function. And it's important to communicate with your patient the need for good nutrition. So let's talk a little bit about abdominal hernias. We know that that's a protrusion of or weakened defect in the wall of the abdominal wall. There are several different types, and they're classified by where the location of the protrusion is. So a little bit about the causes. 10% of the population has some form of a hernia. Groin hernias are more common. Ventral hernias, so in the abdomen, account for about 15% of all hernias. So a little bit more about the pathophysiology of them. An indirect inguinal hernia is tissue that herniates through the internal inguinal ring. A direct inguinal hernia is the transverse abdominis, and the internal oblique muscles remain attached and form a high arch within the abdomen. And a femoral hernia occurs at the fossa ovalis, where the femoral artery exits the abdomen. An epigastric hernia occurs along the midline between the umbilicus and the xiphoid process. These are hernias that are 3 times more likely in men than in women. Umbilical hernia is a weakening in the abdominal wall and this is where the abdominal contents come out through the defect. And it is also dependent on activities that might increase abdominal pressure, such as constipation. And then an incisional hernia is one that occurs anywhere along the surgical line into the abdomen. So how is your patient going to present if they have any of these abdominal hernias? They may have pain when straining or heavy lifting. You may note that there's a swelling in the groin. Sometimes you can palpate the spermatic cord in gentlemen for swelling into the scrotum. Listed here in this slide is the step-by-step for assessing for a hernia in a gentleman. So review that. And then the bottom tidbit is how to assess for a femoral hernia in a female. You can ask them to perform a Valsalva maneuver and then notice any bulging in the area. Epigastric hernias are usually asymptomatic, but you also may notice just a small bump or bulge above the umbilicus, and the patient may report that, and they can vary in size depending on what the inner abdominal pressure has been. Incisional hernias are along the incision line of a previous operation. They can be painful, and they also may have signs and symptoms of a bowel obstruction if the loop of the bowel has worked its way out through the hernia and is not able to retract. These conditions are diagnosed by physical exam, and radiography would only be done to rule out an obstruction. Other differentials might include a hydrocele, psoas abscess in the muscle, femoral adenopathy, inguinal adenopathy, and an ectopic testy. Management is likely going to include referral to a surgeon. With surgery, it's reinforcing the area. It helps decrease the size of the inguinal ring and strengthens the posterior wall of the canal. For femoral hernias, you're going to want to reduce the size of the canal. A synthetic mesh is used when there's not enough tissue. Follow-up with these patients after surgical consultation. Hopefully they'll be followed up with the surgeon about 3 to 7 days after surgery. For a groin surgery, you're able to return to work about 1 week most times, and you should avoid heavy lifting or contact sports for at least 4 to 6 weeks, but that'll be at the discretion of the surgeon. All right, let's talk next about appendicitis. And we know that that is inflammation of the appendix, whether that is caused by obstruction or infection. It's the most common cause of right lower quadrant abdominal pain, requiring a surgical intervention. It can occur at any age, but is most common between 10 and 30. Men are twice as likely to have an appendicitis than women. It can affect 10 in 100,000 people, and is more common in Western countries. And the thought is that our diets are lower in fiber, higher in fat and refined sugars. And typically, it's the obstruction of the appendix by a variety of pathological processes. The patho of it is you will have the dilation of the appendix followed by obstruction, and then bacterial infection can set in. The lumen may be obstructed by feces, an inflammatory process, a stricture or foreign body. The mucosa secretes fluids which distends the lumen, but because there's an obstruction, blood flow is not as it should be, which can lead to tissue necrosis, and if left untreated, arterial inflow can be impeded. And on this slide, we have a little bit about clinical presentation. I'm going to let you read this. We're not going to go over that specifically. I know that on the physical exam, you have reviewed these signs in your health assessment class. So if you're not familiar with those, I encourage you to go over those again. With the appendicitis, diagnostic tests are not usually conclusive. Diagnosis is made from history and physical exam. A CBC may show that you have an elevated white count with a left shift indicating infection. Your analysis may show blood in the urine. If you are going to operate on a female, sorry for the interruption, guys. I believe we were getting ready to talk about doing a pregnancy test to rule out that there was an ectopic pregnancy. X-rays, just plain films, become more important as the symptoms progress. A CT of the abdomen is helpful in ruling out other possibilities. Ultrasound might help visualize the inflamed appendix. And then a laparoscopy may be considered in female patients to rule out an ectopic pregnancy, a tubo-ovarian process, or PID. Your differential diagnoses could include UTI, pregnancy, ovarian cyst, pneumonia, gastroenteritis, diverticulitis, pancreatitis, PID, cholelithiasis. Management of appendicitis is surgeries. You're referring to a surgeon. Preoperatively, it's important to make sure that any correction of fluid or electrolyte imbalances has been done. Bed rest, MPO, IV antibiotics. Narcotics should be avoided as they may mask developing of symptoms. Okay, let's talk a little bit about inflammatory bowel disease. And it's the term used to describe an immunological disease that you see with intestinal inflammation. We have ulcerative colitis and Crohn's disease. And the differences in these is the areas that they impact in the colon. Those individuals that have IBD have a genetic predisposition. We know that bacteria in the gut can cause inflammation, and then there can be an exaggerated cell-mediated immune response to that bacteria. The incidence in men and women is equal. There's a higher prevalence in Scandinavia and Northern European countries. The age of onset is usually in early adulthood. The patho of ulcerative colitis is inflammation to the mucosa in the colon and the rectum. And the cytokines that are released by the macrophages and the neutrophils are what causes the tissue damage. Ulcers can form and abscesses can form in the crypts of the intestine, and areas can become necrotic and ulcerate. Symptoms may include bleeding, cramping, an urge to defecate because of this destruction in the mucosa. Stool is often diarrhea in nature and may contain blood and purulent mucus. With this, you also lose the ability of the GI tract to absorb, and so therefore there's large volumes of watery diarrhea. On Crohn's disease, we know that it's an inflammatory process that begins in the submucosa of the intestine and gradually spreads throughout. 80% of the small bowel is involved. The pro-inflammatory cytokines, interleukins, and tissue necrosis factors can produce areas of damage in the intestine. And there is a section of the intestine called the haustral segments, and these are affected by Crohn's disease, whereas other sections may not, and that's where a skipping pattern is seen within the intestine. These ulcerations form fissures that extends the inflammation. As the disease progresses, the intestinal wall becomes thickened and you have a narrowing of the lumen there, and then the inflammation can cause the bowel loops to adhere to one another, which causes more inflammation and ulceration and fibrosis of the intestine. On clinical presentation with ulcerative colitis, there's significant diarrhea, 4 to 10 bowel movements daily depending on the disease, and small to large amounts of blood and mucus depending on the severity. You have the urge to defecate. There's abdominal pain and tenderness, and there's impaired nutrition and anemia and hypovolemia. In Crohn's disease, it has a slow and gradual onset. The diarrhea may be bloody stool intermittently, and you may notice fat in the stool. There can be abdominal cramping, pain, and tenderness. The patient may have fever and anorexia and weight loss. Definitive diagnosis is made by correlating the symptoms to the H&P. For ulcerative colitis, a colonoscopy may be ordered. Of course, this is all going through your GI doc. You may have a small bowel follow-through with contrast. For Crohn's disease, there may be stool analysis and cultures to rule out bacterial, fungal, or any parasitic infections. You're also going to assess the stool for mucus and blood. A CBC may be done to assess for any forms of infection, and then there's going to be evaluation for malabsorption. You may see anemia secondary to bleeding and iron deficiency. It may be macrocytic anemia due to the inflammation, and you may also notice hypocalcemia and vitamin D deficiency, low albumin, and fat in the stool due to a bile salt deficiency. Management of ulcerative colitis includes nutritional counseling, avoiding things that trigger the symptoms and irritation in the gut, caffeine, raw fruits and vegetables. They need to be on a bland diet that's high in calories and protein. You may prescribe antidiarrheals such as Imodium and Lamodal. The use of medications can be very beneficial. Steroids to help decrease that inflammation, immunosuppressive agents, and then the possibility of surgery. With Crohn's disease, steroids can be beneficial as well. Also, the use of sulfasalazine, immunosuppressive agents, and surgery would be a last resort. With your IBD, these are folks that are going to require lifelong follow-up and intervention based on ebbs and flows in the disease process, and they will require referral to a gastroenterologist. Patient education is important to make sure that they are aware of the need for rest and stress reduction, that they are understanding of the disease process and the importance of dietary and lifestyle changes, and that you provide information and addresses for national organizations such as the Crohn's and Colitis Foundation that can offer important information for lifestyle changes and offer support as well. Okay, I think that's enough for now. We have probably about 30 something slides left, and there's no way we can get it in this time period. So we're going to close this one out, and we will be back to start with IBS. Thank you.